Welcome back after the coffee break. Now we move on to the next session, that is cystic lesions of brain. And I welcome our first speaker of the session, Dr. Ramamurthy sir. I think here is nobody who doesn't know him, a hardcore teacher, and he will talk upon topographic anatomy and differential diagnosis of cystic lesions of brain.
Thank you. Very good morning, and 20 minutes we have to look at the spectrum of intracranial cystic lesions. A fetal intracranial cyst can occur from any intracranial plane or structure. Their anechoic nature actually helps recognition. But however, we must realize that the cerebral parenchyma also is intensely hypoechoic. So to differentiate a hypoechoic cerebral parenchyma from a cyst may be challenging. Also, we realize that the near half of the brain is hidden in the reverberation echoes, and therefore a cyst in the near half of the brain would pose special challenges to be recognized, and small cysts in the posterior due to the bony confines of the posterior cranial fossa as such. So how do we maximize this detection? What in our hands is available to say that I've done this effort so that I have covered looking at the intracranial volume in as best way or as effective way that is possible. So we've got to realize just doing standard axial sections might miss an intracranial lesion. So therefore, we must make it a habit to do a real-time sweep in the axial and coronal planes. This is easy in the axial and coronal planes on a day-to-day basis, but it's tough if you hear you need to do a mid-sagittal sweep. That's a tall question that's a difficult maneuver to do it on a day-to-day basis. But this is easy. So I strongly exhort you all to do a sweep, a real-time sweep, both in axial and coronal, and store your basic axial plane so that you know you've done your little bit to treat the brain as a volume and not as a single slice, right? Also be sensitive to midline shift. If the midline is shifted, your antenna should go up and look at the possible cause which is doing this midline shift, and also visualize the near ventricle, document the near ventricle. When you do the rear ventricle, you're going to do the special effort of going posteriorly, going through the lambdoid suture and trying to look at the near ventricle. In that process, at least a part of this volume is actually unmasked. So you actually get to see a bit of the near hemisphere as well. And again, top to bottom, this is the to and fro movement that we all have to look for. And this is the near ventricle. And you know that you have covered so much of the volume of the near half of the brain, right? Now, once you've detected the presence of a lesion, you need to look at the shape, size, location, and Doppler. And I've highlighted location. Location is extremely important because if you answer in which plane or in which structure is the cyst in, you've literally got your diagnosis. So location is the watchword over here. And from the location, you get into a differential diagnosis, narrow down to diagnosis, and then you're ready to follow up in terms of size and possible obstructive sequelae, right? So you need to look at the other intracranial abnormalities and look at the extracranial abnormalities as such. Now let's come to this issue of intracranial cyst and location. So there are three questions as far as location goes that we need to answer. One is it axial or extraaxial? Axial means intraneural, inside the nervous tissue, or is it outside of the nervous tissue, extraaxial? Is it supratentorial or infratentorial? Is it midline, off midline? So every cyst will try and answer these questions and quickly get at where we are and what is the possible differential and diagnosis. So therefore, once you have a cyst, your basic planes are not sufficient. You need to move to an extended neurosonogram which is in terms of a 3D ultrasound or in terms of transabdominal or transvaginal great images. You need to measure, and also you can do your vascular landmarking. And I'll show you some cases where when you turn the Doppler on, the anatomical region becomes much more clear, and you also have MRI to fall back on, right? So let's look at how to determine whether a cyst is intraaxial or extraaxial. So you need to look at the relationship of the brain to the cyst in question. Now, if the cyst is displaced the cerebral parenchyma, indenting the cerebral parenchyma, or compressing the cerebral parenchyma, you're obviously dealing with extraaxial, and this is a classical example. You see the cyst outside, and you see the indentation which is happening here, an extraaxial, supratentorial, needless to say. Okay. On the other hand, if the brain surrounds the cyst, and if you have a claw sign, the brain tissue is actually embracing the cyst, hugging the cyst on either side, and look at its relation to the lateral ventricle. A cyst which is in contact with the lateral ventricular wall has to be intraparenchymal, isn't it? Intraaxial. And this is a classical example. You see the cyst, its relation to the lateral ventricle, and you see the brain parenchyma, which is actually surrounding the cyst all around. And clearly, you say that this is intraaxial. Looking at the etiopathogenesis, normal spaces, yes. Megacystoma magna, CVI cyst example, developmental arachnoid cyst, interhemispheric cyst in complete agenesis of corpus callosum. It could be vascular in origin, as in a venogallian aneurysm or a dural sinus malformation, and it could be destructive in origin, for example, infection, hypoxia, and hemorrhage, as you can see in the examples out over here. Normal midline cystic spaces, we are all very, very conversant. I'm not going to do anything about it. And we will straight away delve into some extraaxial supratentorial midline. And this is the first case I'm showing you. Cyst, yes or no? Yes. Midline of midline. Supratentorial, infratentorial. Intraaxial, extraaxial. Which is the plane where the cyst is present. This is the Fox cerebri. It is in the interhemispheric fissure. So do your extended sonogram, you find that the fissure is here and your cyst is on one side, your interhemispheric fissure is here, your cyst is on one side, so it's parafall sign. It is in the interhemispheric cyst. On your mid-sagittal section, you see the cyst, and what is missing? You see the vermis, but what is missing? Corpus callosum, that's your MR support over here, and you find the cyst is communicating with the third ventricle, right? So that's a interhemispheric cyst in a case of complete agenesis of corpus callosum, extraaxial, in midline, supratentorial. Again, another cyst. Again, answer the questions: extra, intra, axial, supratentorial, midline, and parafall sign. So again, you have a similar cyst. So you know your answer should come from which plane? Mid-sagittal. So go for your mid-sagittal plane. This is transabdominal, this is transvaginal, and what do you see here? That's the corpus callosum. And what's happened to the rear half of the corpus callosum? Missing, and then what do you have here? The cyst. So therefore, this is a partial agenesis of corpus callosum with a cyst going upwards into the interhemispheric fissure. And needless to say, when you look at the inferior part of the cyst, anteriorly you have the corpus callosum separating it from the cavum septum pellucidum. But when I go posteriorly, the cyst communicates with the third ventricle, and that is the clip telling you that this is a partial agenesis of corpus callosum. Now, can it answer the question whether it's a cyst which has pressed on the corpus callosum and destroyed it posteriorly, or is it a developmental PACC? it's developmental because it's got a direct connection to the third ventricle. And those are the MR pictures, shows you anteriorly the bridge of the corpus callosum between the two areas that we mentioned. And here it is confluencing with the third ventricle because the third ventricle is now deroofed, right? And this is Barkowicz's article on interhemispheric cysts and the classification by Barkowicz, right? Okay, now let's look at this. Again, extraaxial, supratentorial, midline, parafalcine. Yes, this is midline, mid-sagittal section on the abdominal approach. You know you're seeing the corpus callosum. You know you're seeing the cyst there, but how confident are you about the corpus callosum? Now you want to know whether the corpus callosum is there and intact or whether it is partially present, isn't it? So how confident are you in saying, yes, it's intact? Not really. So go vaginal. And when you go vaginal, you find that the corpus callosum is complete, normal. And this is the cyst sitting there, not doing anything to the corpus callosum. And therefore, is this, what kind of a cyst do you think is this? This would be an arachnoid cyst sitting in the interhemispheric fissure. And the same thing, you can see the coronal sweep that you have here. The CC is normal. Now here is a place where, you know, a vascular landmarking has helped you. This is a plane which is lower than your transventricular transthalamic plane. If you were mechanically going to do those two planes, you would miss this. But if you were to do your sweep, as I said, real-time sweep up and down, you would go down and you will pick up that cystic space there. And in a minute, you turn the color Doppler on, you know that the circle of Willis is all around the cyst, telling you that this cyst is coming from the suprasellar cistern. So that is a suprasellar cistern cyst. It could be an arachnoid cyst. You can go coronal, you can go sagittal, and you can go coronal and sagittal with the color on, and you will see the anterior cerebral artery out here, the posterior cerebral artery posteriorly, and on the coronal, you see the two middle cerebral arteries. What proof do you want to say that this is suprasellar? Now let's look at this. Here's a 32-weeker. That's the abdominal scan, supra, infra, supratentorial, intra, extra. Loudly, extratentorial, and which is the last question? It's extraaxial, supratentorial, midline of midline. Midline. So you turn the color Doppler on. First of all, you want to rule out some kind of vascular flow here. You don't have vascular flow, non-vascular. So you have to do your sagittal and coronal sections. Your ventricles are normal, as you can see here, as I've shown you. And in the mid-sagittal section, what you see is the corpus callosum. That's the splenium of the corpus callosum. This is the vermis, and this cyst is nicely sitting between the splenium of the corpus callosum above and the vermis below. Where do you think this is? It's a midline, pardon me? Quadrigeminal cyst. But you have a differential diagnosis, a CVI cyst. So how do you distinguish between a CVI cyst and a quadrigeminal cistern cyst? The great vein of Galen, or the great cerebral vein. So you turn your Doppler on, and when you turn your Doppler on, you find that the vein is above, and so therefore this cyst is quadrigeminal cyst. On the contrary, here you have a cyst where I'm showing you the great cerebral vein is going under. So this is a CVI cyst, right? So therefore, color landmarking helps. Two cases already, a suprasellar cyst, and as well as how to distinguish between a CVI cyst and a quadrigeminal cyst. Vein of Galen, easy. You have to turn the color Doppler on, and you have the typical signature of the draining straight sinus dilated. That's the vein of Galen. These are the feeders. This is sagittal section, and you can do a million things with the volumes that you have. to actually get at different perspectives. So what is the differential diagnosis of a midline extraaxial cyst under the splenium of the corpus callosum, a CVI, which is either prominent or there is a cyst sitting in the CVI, a quadrigeminal arachnoid cyst, a pineal cyst, or a vein of Galen cystic structure. Moving on to off the midline supratentorial, here is a clip. This is what you see. Again, look at this. This is a sweep that is important. And as I'm doing this sweep, can your eyes pick up the cyst there? Yes, that should goad you into doing a multiplanar. And in the multiplanar, I'm showing you the coronal. This was a head up. I couldn't do a vaginal scan. And on head up, I know that this is the tentorium, this is the cyst, and this is the place where it is in the axial view. And in the parasagittal view, not a great view, but I could get this only from the volume. So where do you think this is? Midline off midline. And now answer the question, is it axial or extraaxial? Look at this. Extraaxial, right? And then what is the last? Infra or supra? Supratentorial. Why do you think it's supratentorial? What fossa is this? This is, I'm giving you the word, fossa. How many fossae? Anterior, posterior. Which one does this cystic? Middle. And middle is supratentorial. Middle is where the temporal lobes are sitting, right? And therefore, this is related to the temporal lobe. It is pushing the temporal lobe upwards, and it is actually snugly nestled in the floor of the temporal fossa or the middle cranial fossa. And this is a difficult area. So you take the help of MR. MR shows you brilliantly how the cyst is sitting there. And in a minute on MR, you know that it's an extrinsic extraaxial cyst, which is indenting on the temporal lobe in the coronal view. So that's an arachnoid cyst. Now let's look at this 22-week transabdominal ultrasound. This is a plane which is in your ken, and it's maybe between a transventricular plane and a transcerebellar plane. You find a cyst out here. And in this cyst, midline off midline, supra, infra, supra, and lastly, is it axial, extraaxial? It is extraaxial because you can see this, the hemisphere which is getting indented. So if it's extraaxial, which space do you think comes here around the cerebral peduncles? Ambient cistern, absolutely. So you have the quadrigeminal cistern here, you have the ambient cisterns going on either side of the brainstem, and at a little cephalad, you find the interpeduncular and the suprasellar cisterns. So these are a ring of cisterns around the brainstem, and this is sitting in the ambient cistern, and therefore it is intimately associated with the parahippocampal gyrus and the hippocampus. So you do your multiplanar, you find that it is supratentorial out in the coronal view, and you do your rendering, you can see the cyst much better, and you can do your rotation to show the indentation rather than the intraaxial location, right? Now we'll go on to the infratentorial component, and in the infratentorial component, this is a large cyst which is happening. Is midline or off midline? Midline is large, it's midline going on to either side. Extraaxial, intraaxial. Extraaxial, and it's retrocerebellar or precerebellar. Retrocerebellar, and the cyst is extending above the cerebellum as well, under the tentorium, above the cerebellum. And what kind of a cyst do you think this is? This is the mid-sagittal section showing you the vermis, showing you the cyst as its present retrocerebellar and extending superior to the vermis that you can see here. And these are the corresponding MR pictures showing you a huge posterior fossa cyst. Take your call. Arachnoid cyst, a large arachnoid cyst, and you can see that the vermis is normal in position. Just another, I have another minute, right? On the contrary, here is another 20-weeker. There is a cyst in the midline. I've turned the Doppler on, so it's posterior to the circle of Willis. But what is this? It's a midline. That is the cerebellum. It's extraaxial or intraaxial? Extraaxial. It's extraaxial. Now, supratentorium looks normal except 7 and 7 millimeters, no ventriculomegaly. And you will see that this is anterior to the cerebellar hemispheres. And when I come up, it's posterior to the cerebrum that you can see here. So where would you locate the cyst? Fourth ventricle, third ventricle, supra or infratentorial? Infra, supra, quickly. Yes, that's exactly. You need the sagittal, and in the sagittal, the secret tumbles out so easily. You find the entire brain stem, which is arching over the cyst. Cyst is anterior to the brain stem, and the cyst is out over here, just sitting on the clivus. So it is a cyst between the clivus and the brainstem. So it's a retroclival or a prepontine arachnoid cyst, and the landmark of the brainstem helps you to get your perspective right. Now let's go on to of the midline posterior fossa. That's an example. That is an example of an arachnoid cyst. You can see the wall over here. There is some amount of compression of the ipsilateral cerebellar hemisphere, but you know that this is an arachnoid cyst, which is compressing the ipsilateral cerebellar hemisphere. Good prognosis, bad prognosis? Good prognosis, right? And that is the MR support. And MR is very useful in these instances because in a minute, I know it is not unilateral cerebellar hypoplasia. Can anybody tell me one sign that you can see in the axial MR which tells you that this is an arachnoid cyst and not a unilateral cerebellar hemisphere hypoplasia? Pardon me? Scalloping. Excellent. You can see the arachnoid cyst which has scalloped the inner aspect of the calvarium, whereas here this is normal. This is scalloped, telling you that this certainly is an SOL and not an ab initio hypoplasia. Okay, now this is a tricky one, but then it was tricky to me because this is one of my old cases. You can see that this is the cerebellum retrocerebellar cyst. I've come up into the supratentorial region, and the cyst is also seen in the supratentorium. So it's seen both in supratentorium, infratentorium. Where would you put the cyst? Where would you put the cyst? Subdural. Subdural. It took me some time to sort it out years and years ago, but then after that, the subsequent diagnoses were also easy. So you go mid-sagittal, and you know that the cyst is extra or subdural, pushing the anterior, pushing the supratentorium anteriorly, pushing the infratentorium also anteriorly. You turn the color Doppler on, and that's a huge dural sinus malformation, and you know that you've hit your diagnosis straight. And supratentorial parenchymal, and this is Dr. Malinga's paper way back, which even today helps us and guides us to say what to the patient when you see a intraparenchymal cyst in relation to a ventricle, as depicted by these colorful dots over here. Cystic leukomalacia if the cysts are above the ventricle, a conatal cyst if it's at the angle of the ventricle, and a periventricular pseudocyst if it's under the lateral ventricle. We'll quickly go through some examples. These are periventricular pseudocysts under the ventricle, bilateral, symmetric. You can see the ventricle which is actually compressed and above. And if your Dopplers are normal, you're ruled out infection, there is no hypoxia, so on and so forth. These fetuses actually do well. On the other hand, let's look at this. That's a parasagittal. You see the ventricle there, and you see some cysts. In fact, plenty of them, and that looks dangerous because it's above the roof of the lateral ventricle. It's in the centrum semiovale, and therefore that is cystic periventricular leukomalacia. And here is one case, another case at 25 weeks, showing you a ventriculomegaly, a PVPC under, and a cystic leukomalacia above, and you see the cysts above, those are dangerous. Those are the ones which are associated with poor prognosis. And you also have basal ganglia calcification that you can see here. A porencephalic cyst is a classical intraaxial cyst in the cerebral hemisphere, which is communicating with the ventricle. There is no midline shift because it's a destructive lesion and therefore no midline shift. And intraventricular would be your choroid plexus cyst. Just show that there are no other telltale signs of trisomy 18, and therefore this is a benign lesion, nothing really to worry about. And then of course you have off the midline cyst, and here is a cyst in the cerebellar hemisphere. A cyst like this could be a result of a cerebellar hemorrhage. You can see the lesion on MR as well, and that is the multiplanar imaging. You just have to follow these cysts up and take see that they don't grow and there are no obstructive sequelae. Role of 3D multiplanar is display is really, really good. And of course, you have to look at the relationship to the other structures. You can navigate in a volume, you navigate and you can easily get at the landmarks that you have around the cyst, accurate volume calculation, and sometimes rendering helps you better display, right? So cysts can be typical by their location. Example, a choroid plexus cyst, CVI cyst, or a periventricular cyst. They can be typical by size. Some arachnoid cysts are large, porencephalic cysts are large. Schizencephalies, you can see some of them are large, so on and so forth. Some of them are small, example, PVPCs, CPCs, and leukomyelitic cysts. And some cysts are associated with syndromes. For example, Seckel syndrome is ACC, pachygyria, arachnoid cyst, microcephaly, big nose, and a micrognathia, right? So these are a few things. You can take pictures of this. This is how the algorithm goes for differential diagnosis of extraaxial, right? And this is how and this is for intraaxial. This is for intraaxial. You have your everything comprehensively brought into 2 slides. So wrap up is location of the cyst gives you differentials and then the diagnoses. Color Doppler helps to rule out vascular lesions and also to give you landmarking. Some midline cysts are anatomical and we know that. Diagnosis leads to prognostication. Follow-up necessary to assess growth. 3D ultrasound, MRI are useful. Adjuncts, thank you very, very much for a very patient listening. Thank you.
Thank you so much, sir. You have really awakened the crowd. Now for the next session, we call upon Prof. Gustavo. I need not introduce him again and again. He will speak on our advice, trying to predict histology, imaging challenges in CNS tumors.
Okay, the lecture will be about tumors, but I will only also speak a little bit about cysts because there are many interesting things there. I'm not going to speak about what Ramamurthy spoke, and also I will not speak about periventricular lesions that Roy is going to give his lecture afterwards. So when you have a cyst, they can be extraaxial, we spoke about that. They can be intraventricular, and they can be intraparenchymal. Now, Ramamurthy spoke about arachnoid cysts, okay? And this is another prepontine cyst, and you should understand that even that the pons and the brainstem is very slim, very rotated, is put upward, the prognosis in these cases is excellent. There is not any pathology of the brainstem and the pons that are normal. Although this children was born, and she should be today 11 years old or 12 years old, doing perfectly well. The presence of arachnoid cysts, when you see any arachnoid cysts, please look for the rest of the brain, because also arachnoid cysts that are supratentorial and infratentorial have been associated with malformation of cortical development. I showed you these images yesterday. Always when you see a cyst in the midline, it's quite difficult to understand if this is connected or not connected to the to the third ventricle. But what is important to know is that most probably what happened, this is appear because of pathology of the corpus callosum. The corpus callosum is growing from anterior posterior. Something is missing, something went wrong, and the cavum velum interpositum becomes bigger and bigger and connect due to a disruption with the third ventricle, or they are not connected to the third ventricle, it's only the cavum velum interpositum. But this is something that also Ritsuko showed. Sometimes you will see an extraaxial finding that is cystic, and this is when you use a very good ultrasound machine, you will start seeing what we call dura mater separation. This is completely normal. Don't worry about them. There is not an hemorrhage and there is not a cyst. The differential diagnosis, when you see a cyst, usually retrocerebral, but they can be in any place, a dural sinus thrombosis. What is characteristic of dural sinus thrombosis that you will see the thrombus, as in this case. Sometimes they may appear very early, and you can think that it's a huge arachnoid cyst, but actually this is a case again of a dural vein thrombosis. Periventricular parenchymal cysts, like, as again Ramamurthy spoke about that. This is the original picture showing the place. I don't know, and there are multiple synonyms. For me, conatal and periventricular and germinolitic cysts are exactly the same. They are very common, okay? And we published years ago 9 patients. In 5 cases, disease were isolated and the prognosis was good. There are other papers also in children show that there are no developmental differences between those that have cysts and don't have cysts. But the differential diagnosis is quite big of periventricular pseudocysts. Many times they can be associated with CMV. This is the most common pathology, but actually it's much more common the normal variants. If you have a fetus with a small head, intrauterine growth retardation can be a -4p deletion in Wolff-Hirschhorn syndrome. They can be metabolic, including glutaric aciduria and Zellweger. They can be mitochondrial, and we saw a case presented with mitochondrial depletion. It can be a single mutation, a DNA mutation. So in these cases, it's very convenient to try to perform West, and Roy is going to speak about this different etiology and some undefined syndrome, and it also associated many times with cardiac malformations. Okay, and here you have all these normal variants. They may be single, they may be lateral, they may be multilocular, they may be bilateral, multilocular. If there is not anything else, and you are sure there is not the IUGR and not other malformations, usually the prognosis will be very good. And remember that sometimes they may be recurrent in 2 different pregnancies, one after the other. And it does not mean that it's an autosomal recessive disease. It means that it can happen in two consecutive pregnancies. I am not, this is a periventricular cyst, but actually there are destructive processes that occur usually associated with other brain signs of CMV. This is a case by Waldo Sepúlveda as huge cysts, and it was a case of glutaric aciduria. The treatment of glutaric aciduria is possible to do a postnatal treatment, so these children do well. This is a case that the patient come to us at 38 weeks, and I saw this small periventricular cyst, and she passed away at the age of 3 months because of Leigh syndrome. Perhaps it's an incidental finding. It's not related to the disease, but was there. Again, cases of periventricular leukomalacia, and this is an important case. It's a case of fetal stroke that we make the diagnosis very early, so we were able to see that the echogenicity of the finding that it's not cystic, but as pregnancy progresses, it become a periventricular cyst. Okay, and you see here how it connects at some point with the lateral ventricle, and it turns to be a case of COL4A1 malformation. And you can see here, as Moran showed you, the associated white matter, abnormal white matter, when you perform a postnatal MRI that was not seen was not diagnosed during pregnancy. These are porencephalic cysts that are not close, not related, and quite big, not related to the lateral ventricles. And this is a paper by the group of Catherine Garel that they call subependymal pseudocysts all cysts that was around the lateral ventricles, but actually most of them were not true periventricular cysts, but were associated with CMV infection. So if the cyst is very big or is positioned occipital or temporal, be aware that they are not periventricular pseudocysts. And the intraventricular cyst, and now we start speaking a little bit about tumors. Okay, those are the choroid plexus cysts. They can be small, they can be big, and we saw the presentation of the abstract. But remember that sometimes, and we have one case, and there is another case from Germany, that if the choroid plexus cyst is close to the Monro foramen, they can go through the Monro foramen and produce unilateral hydrocephalus. And this is, they enter the cell ventricle and they go out. They enter and they go out. So they can produce ventriculomegaly. The ventriculomegaly may disappear and may appear later on. Usually the prognosis is good. Again, here you have this choroid plexus cyst early in pregnancy, but this associated malformation, this is a case of trisomy 18. So again, you should look for associated malformation. Now, if your first trimester examination, rarely will see a choroid plexus cyst. Usually choroid plexus cysts appear by the time that we perform amniocentesis, 17 to 18 weeks. Okay, and they disappear around 30 weeks. Usually they disappear, not always. But this is a particular case because the physician that performed the examination is very pedantic. He performed 3 or 4 ultrasounds and everything was okay. But at 28 weeks of pregnancy, he diagnosed this choroid plexus cyst. So he referred the patient to us to see, because it's very rare to see what perhaps you will look. And when she came to us, before she traveled to the United States, she came back. So we see the patient quite late in pregnancy, and you see what happened. This small cyst become a huge one. This is the lateral ventricle, and this is the cyst. And what was interesting that the sulcation was not present. So it was very difficult for us to realize if this is a malformation of cortical development or there is due to edema. So here you have the orthogonal planes by ultrasound and the orthogonal planes by MRI. And again, the abnormal surrounding hemisphere was considered most probably due to edema. And the girl was born, and here you have the cyst that actually is called plexus papilloma. And after operation, the reduction in size and the normalization of the sulcation because the edema disappeared. So all these changes in the MRI and the ultrasound were due to pressure. And this is the girl, and she's bending not because of an neurological problem, but she's dancing. Everything is okay. You see? Now, the differential diagnosis, as in this case, is the possibility of intraventricular hemorrhage grade 4, as in this case. So the moment that you move the probe, you understand that there is something else. This is not a choroid plexus cyst. So take-home message regarding the cysts. Intracranial cysts are not rare. Intracranial may arise from different brain structure. CPCs and arachnoid cysts are frequent and associated with a good prognosis. And counseling is based on the performance of the tail neurosonographic examination. And in some cases, you will need to recur to MRI, as I show you. Now we go for tumors. Tumors are quite boring because you do the ultrasound and you know that there is a tumor and you know that the prognosis is bad and there is not much to do. Now the list of congenital brain tumors is quite large. Most of the congenital brain tumors, although they are congenital, they are not diagnosed during pregnancy. They develop later on. And the differential diagnosis. This image is also in the book, and I put images like that because you have 3 different masses, okay, that are quite similar one to the other. Knowing the position of the mass, you will try to make a etiologic diagnosis, okay? And most people say, okay, this can be a craniopharyngioma because it's solid and it comes from the base of is in the position in the basal cistern. But actually, this is a teratoma, this is a craniopharyngioma, and this is an astrocytoma. So based in ultrasound, you can try, but the chances that you are wrong are quite big. In any case, in all these cases, as I told you before, the prognosis is not good. Another important thing is to differentiate between, I am showing from the other side, to differentiate between hemorrhage and tumor. And again, the way to differentiate is by putting color. Now, teratomas, strange, very, can be cystic, solid, partially cystic, partially solid, as in these cases. Here you have other teratoma. Sometimes the teratomas may protrude or destroy even the face or went out through the mouth or through the eyes. Okay, as in these cases, this one of these is from Timur, and I think the other is from Dario. These are astrocytomas that are characterized, again, there can be solid cystic, but usually teratomas, you will not see intratumor vessels. In astrocytoma, there are a lot of intratumor vessels. And this another one that we have in our hospital, again, with a very, very bad prognosis. The moment that you put color, you see that it's very rich, a lot of vessels, very bad prognosis. This is a neuroectodermal or primitive neuroectodermal tumor, PNET, that was diagnosed by Daniela, and this is the post-operative MRI, and in this operation went okay. So there are exceptional cases that the child can do well. Now this is one we saw 2 or 3 years ago. There was an intracranial mass that was diagnosed during the 2nd trimester, but the patient didn't consider termination because of religious. She went for consultation all around Israel. Soroka is in the south, Volson is close to us, and also pediatric neurosurgery in our hospital. And she was referred for cesarean section at least. And what we saw, there's a huge head circumference with a very large biparital diameter. And they come with the MR that the mass was apparently mostly cystic, okay, with frontal bossing. And when we did the examination, we saw the mass with the presence of vasculature inside. And in these cases, we always ask to speak with the person that decide if to continue pregnancy or not. That in rare religious people, they are not the parents, but there is some religious authority that tell them if to do that or no. And one of the things that can be reason to perform a late abortion or abortion at all is the health, is the risk for the mother. And another important thing is the risk that she will need to undergo hysterectomy or some complication. So if the mother is in danger, it's accepted. So in these cases, we tell the head is very big, we will need to go for cesarean section of a very big head. It can be complications, the uterus can be ruptured, we will need to do hysterectomy. She will not be able to have other children. So the rabbi say, okay, I understand, go ahead. And we perform termination of pregnancy. And the diagnosis is, again, of a high-grade neuroepithelial tumor, the PNET. These are craniopharyngiomas. They also usually come from the Radke pouch, and they're in the cisterna, in the basal cisterna. Now, this is an interesting case because the patients come to us because of rapidly developing ventriculomegaly, and they were not in the other hospital. They didn't understand what exactly it happens. But when you look, you see that the mass is positioned in the third ventricle. So we need to differentiate between the possibility of an hemorrhage in the third ventricle and choroid plexus papilloma. The moment, again, that you put color, you see that it's not an hemorrhage, and it was a choroid plexus papilloma. Okay, again, you see the video, you see how the third ventricle is dilated. There is no fluid inside. This is because that you have the new origin of the ventriculomegaly, and here you see the Doppler. Okay, the prognosis of choroid plexus papilloma is good. So this is the prenatal MRI. Again, the MRI was not able to tell if it's a tumor or not. After delivery was quite clear, and this is the postoperative MRI. And we follow this boy, and he did exceptionally well. So congenital brain tumors are rare. Prenatal diagnosis even rarer, usually during the third trimester, and there is poor prognosis with the exception of choroid plexus papilloma that may have a better prognosis. And thank you, and I think that it will be my last lecture.
Thanks, bro. Any questions?
My question to Dr. Ramamurthy, sir. Sir, can we call the axial or extra-axial parenchyma or extra parenchyma also? Or any lining of that cyst matter? Sir, you were saying axial or extra-axial. Sir, can we call them parenchymal or extra parenchyma also?
Use the word parenchyma for neural tissue, you could.
Can the lining of matter, the cyst matter, sir?
Yeah, lining depends on the origin. If it's an arachnoid cyst, you'll find an arachnoid membrane there. So histopathology always, if there's an operative outcome, then of course histopathology is available. You can support it. Not an issue.
Thank you, sir.
Gustavo, the girl which was dancing, what was the final diagnosis? Which was dancing, the dancing girl. Yes, but it was cystic. The papilloma are not cystic. They are highly vascular solid tumor. But
There are cystic choroid plexus papilloma. Actually, it was not a intraventricular papilloma, but was an extraventricular papilloma in the brain. There is only another case that I'm aware of that. It comes from Japan years ago.
so you agree that it's a very, very rare presentation of a papilloma, because most of the papilloma are, as you show in the last cases,
They're solid.
tumor solid and with very high vascularization.
They did the histology because they operate on her, and this was the diagnosis: choroid plexus papilloma intraparenchymal. It did come from the or it was an invasion of the parenchyma.
Okay. Very
But again,
exceptional.
it's not a choroid. It was clearly not a choroid plexus. Was not clearly a choroid plexus cyst because it grows and it becomes multicystic. But look at the literature and put multicystic or cystic papilloma of the lateral ventricle, and you will find some cases.
So we welcome Dr. Roy Bandam again. He will speak on periventricular area lesions, germinal matrix problems.
Hi, good morning, everyone. I'm happy to be back and enjoyed so much the previous sessions. Just please tell me if you see me as a full screen mode. Because I'm not sure on the full screen mode.
Not yet, sir. Not yet.
Okay, so let me just try to fix
Yeah.
that. Okay, now is it in a full screen mode?
No. Yes, sir.
Okay.
Yes, sir. Yes, sir.
Okay, so good morning, everyone. In the final talk regarding cystic lesions, I will try to focus on an entity that has been just only recently in the last few years has been came to our attention as clinicians. I think this should be highlighted and regarding the ganglionic eminence eminences, because this term has been described in some of the previous talks that you heard, but I'm not sure all of us are aware exactly what are the ganglionic eminences and how important these structures are. So let's start with a little bit embryology. The ganglionic eminences, if you perform a coronal cut through the anterior telencephalon early in pregnancy, you come up with this image of the brain. You see that the dorsal part of the brain is very thin, where the cortex starts to develop only very primitive cortical plate. However, if you look on the ventral section of this cut, you see it is quite thick. And this thickening here is composed of two areas. The ventral area, the lower part, is composed of the developing basal ganglia and the neurons that comes down, all the fiber tracts that comes down from the cortex into lower areas. However, on top of this area, we have these two bulgings on both sides that you can also see that on the histological sections, they appear differently and they bulge into the floor of the lateral ventricles. This is why they are called the eminences, and you have 3 of these eminences. And these structures are extremely important because during early pregnancy, this is the place of most proliferating events of the neuroepithelial cells before they embark on their migration. And from the ganglionic eminences, you have different subfamilies of neurons which will depart. Some of them are the GABAergic inhibitory neurons that go on a tangential migration to the cortex. Some of them will send neurons to lower areas, and there will be the bones of the basal ganglia. So remember these areas, and these events mainly occur during early pregnancy. What happens to this ganglionic eminence, or generally speaking, to the proliferative areas of the brain after the neurons finished to proliferate and the last waves of migration departed away? So you see that during pregnancy, the germinal matrix, which is stained here in the black stain, gradually decreases in volume and in size. And eventually during the 3rd trimester, we have mostly remnants in the caudothalamic groove, which is a little bit behind the head of the caudate and the anterior to the thalami. But you need to remember that during early pregnancy, mostly the first half of pregnancy, there's a lot of cellular activity and proliferative activity going on there. And you also need to remember that this activity has a very high energetic demand. Now, a very important point for us as people who are doing ultrasound to remember that both on the histological staining and also on the MRI, and this is images from one of the fantastic papers by the group from Zagreb, by Kostovic, you can see that the MRI, this is a post-mortem MRI, but also in vivo MRI, and the histological staining, you can clearly differentiate between the different basal ganglia, the putamen, the thalamus, and the head of the caudate, and to differentiate this between the actual proliferating layer, the germinal matrix here, and you can see it here in the dark stain in the atlas by Bayer and Altman. However, this tissue differentiation is much more difficult and much more less evident on the ultrasound. So we need to understand the anatomy and to know where are we in order to understand that in this location, we are expecting to have proliferating cells of the germinal matrix. And you can see here in the coronal images, they are here on top of the head of the caudate, just creating the floor, the inferolateral floor of the anterior horns of the lateral ventricles. And on the parasagittal image, we have this complex, which is composed of the thalamus, the choroid plexus, the caudothalamic groove here, and the head of the caudate, which is wrapped with the cells of the ganglion of the proliferating germinal matrix, which was originally the ganglionic eminences during early pregnancy, as I showed you. And during later pregnancy, 3rd trimester, these are the area you should be looking for. This is the parasagittal image. Again, the caudothalamic groove, the thalamus, and the head of the caudate. I will not talk about the later events that occur in the germinal matrix because you've heard fantastic talks by Dario, by Daniela, by Moran, and by Gustavo regarding various insults that involves the germinal matrix here. It can be all the variety of bleeding, infection involvement, and we describe this unique phenomena that occurs during third trimester, in which the germinal matrix of the head of the caudate become echogenic in CMV cases, and we describe the outcome of these children, and also the PVPCs, the periventricular pseudocysts that Gustavo described, and we know today that, and this is according to a few, some literature, that when isolated, these findings carry very good prognosis, regardless their size, their laterality, etc. So you need to just confirm that these PVPCs are isolated, and I will not discuss more about this because you've heard about it. However, I would like to show you an interesting case to show you when we are talking about isolated, you have to be very careful in looking for the additional findings. This is a case that was referred due to simple, isolated, non-significant periventricular pseudocyst at 22, 23 weeks after one of our colleagues who is a very good sonographer, he found them on a screening examination, and you can see he was correct. There was actually these two periventricular cysts in apparently normal appearing brain. However, I performed this examination because I wanted to be sure that this is completely isolated. And if I run this video, did you see the abnormality here? I will let me run another video because once I saw these small lesions here, I was focused on this area, and you can see here in the parietal area, just below the bones, you need to come up with the perfect insonation window, and then you find this insult, small insult here. So now we were much more concerned than just saying, well, this is a benign isolated finding. We performed the performed amniocentesis. The array was normal. However, we continue for the whole exome, and we found the pathogenic variant de novo in a gene called ATRX gene. This is not the ARX with the lissencephaly. This is ATRX. It's a different gene, which is known to be involved in developmental delay and intellectual disability, and the couple decided to go for termination of pregnancy. However, I would like to focus and to shed more light on earlier events. As I told you before, this is something that has, until recently, and thanks to the group from Italy, we were not really aware of this pathology. But going back to the physiological and embryological work by Kostovic and the colleagues from Zagreb, you can see that if you look at the developmental events and the cellular events that occur during morphogenesis of the brain, most of the important things with the highest extent occur during early fetal or mid-pregnancy around these areas. You can see proliferation, migration, specifications of cells. For example, we talked about it in the corpus callosum talk. We have the specification of callosal neurons, etc., etc. So it doesn't come to a surprise that if this cellular factory is involved or insulted early in pregnancy, we would expect to have a quite disseminated effect on brain development. How does this area look on ultrasound during early pregnancy? So you can see all the three orthogonal planes and with the corresponding histological images. This is a parasagittal image. You can see the bulgings into the lateral ventricles in normal fetuses. You can see here on the axial plane view, these echogenic bulgings into the lateral ventricles. And I talked about the choroidal fissure and how to differentiate these between the choroid plexus. And also on of course, the coronal images, you can see these two bulgings that come from the inferolateral walls of the lateral ventricles, and these are the areas here. So once you are aware of the anatomy, you will be able to pick up the pathologies. Now, just recently, a few months ago, we published this work in which we aimed to describe the normal developmental patterns that occur in the parasagittal images. Now, the reason that I show you this paper is because the parasagittal image is the place for you to study the ganglionic eminence on ultrasound, taking into consideration that we are limited, as opposed to the MRI, we are limited in differentiating between the two layers. So we have this ganglionic eminence basal ganglia complex here, marked by C, and then you have to put your eyes and to differentiate this area between the choroid plexus and the mantle of the brain. And interesting, what we found is that if we look at the location of the choroid plexus, the anterior, how much does anteriorly the choroid plexus extend during early pregnancy, you can see that at 14, 15 weeks, you have most of the cases or a significant fraction of the cases, the choroid plexus extend anteriorly, which is at the level of the ganglionic eminence. And this point you have to take into consideration because you need to, in your eyes, to differentiate between the anterior extension, as for example, in this case, of the choroid plexus and the location of the ganglionic eminences. So bear this anatomical point in mind when you're studying the early brain. Now, as we mentioned before, this is the factory. So what happens when you have pathologies of the ganglionic eminences? And I think that most of our awareness came from thanks to Andrea Rigini, is there with you. He was the first, his group was the first to describe 10 years ago a small series of cases, all of them diagnosed on MRI after 22 weeks, and all of them had abnormalities of the ganglionic eminences. And this is their series of cases, and you can see exactly the anatomic location that I showed you on the ultrasound. And what they found that this is not a benign pathology at all. It involves many different brain structures, reduced brain biometry, callosal malformation, abnormalities in gyration and sulcations, and also heterotopia, which is a big part of malformation of cortical development. Now, after this publication, and this is also a correlation with the histological, you see the detachment of the ganglionic eminences, the proliferative section from the basal ganglia. Recently, again, from the group from Italy, led by colleagues from Milan and the rest of Italy, this is a multi-center study which included 60 fetuses. All of them were scanned and diagnosed by MRI at around 23 weeks of gestation. And if you look at the list of involved structures in the entire brain pathology, in those cases that had bilateral cavitations, you can see here that you may come up with this checklist of the structure that you must look for whenever you are suspecting a ganglionic eminence pathology, because as you can see, and as I told you, this involves almost the entire brain. So you might have lamination abnormalities, midbrain, hindbrain abnormalities, cortical malformation, the corpus callosum is frequently involved, you might have ventriculomegaly, or abnormalities in head biometry, either macrocephaly or microcephaly, or normal head biometry. So remember this pattern, because all of these structures might be involved to various extent when the ganglionic eminences are involved. Another interesting paper coming from the same group is they try to correlate the phenotype of the head biometry with the genetic results. They perform extensive genetic studies to these fetuses, and they had three groups, either the macrocephalic, the microcephalic, or the normal head circumference. And you can see that they were able to find different genes involved. And I think all of you are quite aware of these genes. They are well-known genes involved in malformation of cortical development, the different tubulinopathies, the mTOR, etc., etc. So again, as you can see, this is a significant malformation as opposed to the same location, the PVPCs, the germinal matrix during third trimester with absolutely almost no clinical significance. But when the pathology is earlier, as I told you, this is significantly a different outcome. Now, what about the ultrasound? The first description of ultrasound diagnosis, again, came from colleagues in Italy. This is a letter that published in the White Journal in 2019, in which they described two consecutive pregnancy, two siblings. The first one was diagnosed at 23 weeks. However, the second one, because they knew that there might be a family history, they called the patient to come earlier at 16 weeks, and in both of them, they were able to find the cavitations of the ganglionic eminences. And as the authors quote, the MRI confirmed the asymmetric cavitation within the hypertrophic ganglionic eminences. However, in addition, the MRI was able to show an abnormal signal of the parenchyma, like lamination abnormalities, hypoplastic corpus callosum, and gyration abnormalities. And according to the authors, this was only picked up on the MRI. Now, let me show you some of our cases. This is a patient that was referred because of a suspected abnormal corpus callosum at 22 weeks. Now, when you look at these images, I think you can see the entire list of anatomic structures involved. First of all, if you look at the ganglionic eminence, they're large, they are cavitated, they're lifted up, there's an insult going on here. But bear in mind and put your eyes here on the lamination pattern of the brain. You can see very nicely this is a very abnormal lamination. Probably there's also a beginning of a cystic detachment or insult going on here. And you can see this echogenic rim around the ventricle, which should not be here. At this stage, you should only see the subplate and the intermediate zone and their interfining line. But here you have like a 3 layers appearance, which is a completely pathological laminations. You look on the parasagittal images, you can see the cavitation and the uplifted ganglionic eminence bulging into the lateral ventricles. You see the parenchyma is small. There's a lot of fluid surrounding the brain, and this echogenic lamination, abnormal lamination that surrounds the brain. And when you're looking for the corpus callosum, it's there, but it's very small and dysgenetic. The patient performed the whole exome sequencing, and this came out to be a pyruvate dehydrogenase deficiency, like in one of the cases described earlier by Andrea Regini. So this is a significant mitochondrial disease. The patient went for a termination of pregnancy, and we performed the autopsy. It was performed by Professor Kidron, and these images are from her. And you can see here, there's a disintegration of the germinal matrix here, You can see a heterotopia, which probably correlate to the abnormal lamination that we saw here. And there are foci of cortical thickening as marking the abnormal cortical formation in these cases. This is another case that was referred to us at 22 weeks after, because of someone thought he saw an early CPC, choroid plexus cyst, at 15 gestational weeks. So you start your exam by the axial view, the transabdominal axial view. And once you see this image, you know that there are no CPCs here. You see the cystic cavitations, but you know that they do not involve the choroid plexus. They involve the ganglionic eminences. You can see also the mildly dilated lateral ventricles. And if you put your eyes here, you see there's too much fluid behind the brain. There's not enough brain parenchyma. Also, the Sylvian fissure is very flat and very shallow here. So only from this image, you know that there's a significant problem in this brain. It's not just a benign CPC. It's not a CPC at all. So you perform a detailed neurosonography, and you can see how insulted, how damaged is this brain. Again, the cavitation of the ganglionic eminences, thin parenchyma, abnormal lamination, abnormal corpus callosum. And once we saw that, we understood that originally these were not choroid plexus cysts. So I asked the patient, go home and please, with your mobile phone, take a picture of one of the pictures that the doctors gave you after you finished your early anatomy scan. I want to see the CPCs, and let me show you what she sent me. And these are the allegedly CPCs. And I think now that you know what to look for, you understand that these were not CPCs. These were ganglionic eminence cystic cavitations. And once we had additional 3 or 4 cases with the same pattern of false diagnosis of early CPCs, we published this letter in the White Journal together with Gustavo and me and Dr. Brusilov and Nina, and saying that be aware of these minor issues that I'm trying to raise here, because if you see these early CPCs, like in this image, be aware, and you should suspect that there's a significantly much worse prognosis because these are not CPCs. This is another patient, interesting one, that was referred again after someone was aware to the fact that there is a ganglionic eminence cyst. She was correct, the referring physician was correct, and she sent her, and let me show you the images at 15 weeks. You see the cavitations of the ganglionic eminences. However, the brain was not so much involved. It was not such a significant brain abnormality. You see the vermis, maybe a little bit lifted, but completely normal brainstem. The corpus callosum is here. The only thing that I was concerned about is a little bit the lamination, the thickness of the parenchyma. It appeared to me a little bit thin, but we could not say for sure that the findings now are bad, but we told her that due to the early insult of the ganglionic eminence, the prognosis is most probably going to be bad. She decided to continue with the pregnancy and in a wait and see. So she came back at 18 weeks. And again, you look at 18 weeks, the brain is not so significantly affected. You have the corpus callosum is here, a small CVI, the vermis has developed nicely, and the parenchyma is here. It's not so thin. You have a nice lamination. However, I was still a little bit concerned about the echogenic lamination here, but these are very, very subtle findings. But of course, we told her you should go for the genetic assessment, and she performed the CMA, and the CMA came back positive for a pathogenic duplication, which involves this list of genes, and she went on for termination of pregnancy. So you can see that you might have some kind of a variety within the findings. Maybe if she had continued the pregnancy and we saw her again at 3rd trimester, you would expect to see some cortical abnormalities, but she decided due to the results of the genetics to go for a termination. And coming up to the end of my talk, I want to show you a very interesting case. This patient I saw at 17 weeks because she was referred because someone thought that the lateral ventricles are a little bit pronounced, around 7 millimeters, but still within normal range. And the humerus and the femur were a little bit shortish, but not too short. And she came to me at 17 weeks, and the first thing I did was to perform the transabdominal, a quick look. And only when you see this image, you understand that there is a significant problem in this brain. It's not about the lateral ventricles. So we performed a complete neurosonographic assessment. And what you see here is everything that I showed you. The whole brain is involved. You see the cavitations of the ganglionic eminences. There's a very pathologic lamination pattern of the brain. there's a very thin and underdeveloped anterior hemispheres with a lot of extraaxial fluid surrounding them. And just for you, this is a nice example to show you the difference between this image and those cases with a CPC or a cribriformic CPC in a completely normal ganglionic eminences. So pay attention to this, the difference between these two images. This is a completely normal outcome, as you can see also in the parasagittal image, as opposed to this significantly insulted brain. Now we continue with our neurosonography. You go to the parasagittal images, and this is a normal control just for your eye, for your pattern recognition. You see very, very thin brain parenchyma, very abnormal lamination, and this huge cystic ganglionic eminence which protrudes into the lateral ventricle. You can see the communication between the wall of this cyst continues with the tissue of the ganglionic eminences themselves. Now we continue further on with the neurosonography. You can see there's a complete agenesis of the corpus callosum. There is no corpus callosum along the midline. And also, if you look, when I looked here, I had a feeling that also the midbrain, hindbrain is involved. So you perform also a posterior approach neurosonography, and you can see here I could barely see any Vermian fissures at 17 weeks. You would expect to see them clearly, as you can see here in the normal control case, and I failed to recognize them here. So you also rotate in 90 degrees, and this is the mid-sagittal image. And as you can see here, compared to the normal age matched, and you see the vermis is completely underdeveloped. This is an abnormal pathologic vermis. Also the midbrain, the tectum here is pathological. And again, if you're not sure, compare it to your normal atlas or in your mind or on your machine. So due to the severity of this malformation, the patient went for a termination of pregnancy, and we performed a trio whole exome to the parents and to the child, to the fetus, and we found both parents were carriers of a variant in a gene called NDUFAF5, and the fetus was affected by both of he was homozygous to the mutation. Now, what is this gene? This gene is very interesting because it has just recently been described as one of the causative genes for bilateral striatal necrosis in children, which is a degenerative disease of the basal ganglia in children with a progressive deterioration. And what is this gene? This gene is responsible for a protein. This is a nuclear gene, but it produces a protein, one of the assembly proteins of the mitochondrial complex 1, which is the first of the respiratory chain of the mitochondria. It's the first station. And if you have an abnormality in one of the assembly proteins, you come up with a mitochondrial disease. However, the gene is a nuclear gene. And this is not surprising if you have a mitochondrial disease. As I showed you before, also in the pyruvate dehydrogenase, the factory, which is a highly energy consuming structure, it becomes insulted and cystic and degenerated, but this has never been described in fetuses before. And now that we know that the parents are carriers and they have, as you all know, 25% recurrence risk for autosomal recessive disease, I called the patient and I told her, listen, we need to have a very thorough consultation because you might have a recurrence risk of 25% and we need to consider IVF and PGD, etc. And she stops me and she said, doctor, it's very nice of you to call me. You're very nice, but there's a little problem because I'm pregnant. So I told her, okay, if you're pregnant, please come immediately to my clinic. I want to examine you. And she told me, yeah, but this is not our biggest problem because our biggest problem is that I have a triplet. So I told her, okay, go into your car and come to my clinic now. And she arrived to me at 11 and a half weeks with a triplet. And I told her, come now because there's a good chance that if one of them is affected and he has the disease, we might be able to pick up the malformation already at 11 weeks. And let me show you the neurosonography. This is fetus A. We perform a transvaginal exam, and you can see here the ganglionic eminences and the choroid plexus in a completely normal brain. Let me show you fetus B. Again, the neurosonographic examination shows a completely normal ganglionic eminences and the choroid plexus in a normal early brain, as you can see here also on the parasagittal images. But now take a look at the fetus C. And you can see clearly here that this fetus is sick. He has a cystic enlargement of the ganglionic eminences. Don't mistake these findings with the choroid plexus. This is an affected child. and they went for a selective termination of this fetus. We performed the termination. We confirmed the genetic disease. He was homozygous to the mutation. We continue with amniocentesis to the remaining two fetuses. One of them was completely negative, and the other one was just a carrier, as is their parents. And 1 year ago, she gave birth to two healthy twins. And it's a very interesting story. Remember these cases. And thank you very much for your kind attention.
Thank you, sir. I think we have questions for you.
Rui,
Okay.
good morning, Vivek here. Fantastic work and amazing presentations, Rui. I just have one
Thank you.
question. In literature, we very often see the terms germinal matrix and ganglionic eminence used interchangeably. Are these one and the same in terms of neurogenesis, or are they different? And second part of the question is, should we start calling germinal matrix hemorrhage as ganglionic eminence hemorrhage in that case?
Thank you for, hi Vivek, how are you? It's good to see you. Thank you for this very important question. The issue is a terminological issue. Originally, the ganglionic eminences are called eminences because they have been described early in pregnancy as part of normal embryology, and because the ventricles are very big, the brain is thin, and only the ganglionic eminence protrude into the lateral ventricles. These are called eminences. As I showed you, what happens with time is that the brain develops and the amount of proliferative cells decrease, so you come up with the germinal matrix. So it is common, it is commonly referred as germinal matrix later on, once proliferation and migration occur, and you have remnants of germinal matrix and vulnerable for all the insults that you heard in previous talks. And the ganglionic eminences usually are saved for the earlier stages of pregnancy when they actually protrude. So I think in terms of terminology, if you have these early insults at around 20 or 22 weeks, and you can see the ganglionic eminence, sometimes they are prominent or large, or they fail to develop, as you could see in the works by Regini. So you call them ganglionic eminence cyst. Usually you imply that there's a significant abnormality. On the third trimester, these are more general matrix, PVPCs or germinolytic cysts, as I showed you, and these are remnants of matrix with no cellular. So I think it's more of a terminological issue, and if you're not sure, it's better to describe the time and what do you see, so everyone who reads your report understands exactly.
But from a neurogenesis perspective, because ganglionic eminences will predominantly produce GABAergic inhibitory neurons. So does that have any impact in terms of clinical outcomes when you have a problem with the ganglionic eminence compared to a germinal matrix insult?
Yeah, that's what I showed, because in ganglionic eminences, you still have the cells. The cells are there. They have not migrated yet, or they are during migration. Germinal matrix, by definition, is the remnants of the tissue, all these febrile small vessels that are stuck there, leaning the epithelium, and might also bleed later on in pregnancy once you finished your migration. So, of course, it has a clinical significance. This was the whole point of this talk, to show you that early in pregnancy, when proliferation occurs and you have an insult or an energy deprivation, of course, you have a significantly different clinical outcome and impact on brain development.
Thank you, Dr. Rui, for such an interactive session. Now, session 9 has been merged with session 12. So directly shifting on session 10, that is the intrauterine infections affecting the CNS. And first, I'd like to call upon Dr. Dario for the imaging and diagnosis. Over to you.
Yeah. Okay, last effort before lunch with infections, and I share this with Anita. So let's start with the main player, which has been so far cytomegalovirus infection. You know that the prevalence of the condition is different according to the geographical region you are in. So it depends on what is the seronegative prevalence in pregnancy in India, which I'm not aware of. but as far as I know, it should be as high as in Europe. You have 1% of seroconversion in pregnancy with 30 to 50% vertical transmission rate, and the prevalence at birth of 0.5, and a perinatal mortality which so far has been rated at within 5%. Notably, CMV is the most common non-genetic cause of hearing loss, neurosensory hearing loss, and also a contributor to permanent neurologic disabilities in children. And the key point until now is that pregnancy screening has not been deemed mandatory. So until now, all over the world, there have been no ongoing screening such as for toxoplasmosis. But now the situation is changing, as I'll show you at the end of the talk. As for the epidemiology, we formerly used to think that if you had a recurrent infection or infection, this would be of lesser importance, but this is not the case because as you see from these studies, prevalence studies, 50% of their infections are responsible for fetal cases in France, and the same in Finland. So non-primary maternal infections explain 50% of congenital cytomegalovirus infection in pregnancy. The second concept is that symptoms at birth in the neonates may be present irrespective of the time of maternal infection. So they occur regardless of the fact that you have been infected in the first, second, or third trimester. But what does change is the fact that major neurodevelopmental delay and cerebral sequelae, as well as neurosensory hearing loss, do appear only if you have a seroconversion or infection which is limited to the first trimester of pregnancy. There are very strong data published on this issue. So if you have a late seroconversion, and by late I mean second trimester or even later, you can reassure the couple because it's only some concern for neurosensory hearing loss, but not for major cerebral abnormalities leading to neurodevelopmental delay. The reason why you have a cerebral damage in the fetus in case of CMV infection is brilliantly shown by several groups who have worked, and this is one of such papers, showing you that there is a kind of magnetic attraction between CMV and neural stem cells. And this is why you have this kind of major localization of CMV at the level of the fetal brain. Now, as far as our everyday life is concerned, you may have two scenarios. The first one is that you carry out a screening, ultrasound, and then you refer the patient because of suspicious something going wrong with the brain. And then you have some of the lesions that are suspected that may point to underlying CMV infection detected at neurosonography. Or the other scenario, which until now was much less common, is that you are referred a pregnant woman with a confirmed seroconversion. So she had regularly undergone on her own initiative or of OBGYN monthly checking IgM and IgG for cytomegalovirus. And if she seroconverted, then she is referred for an expert assessment. And these two scenarios were completely different in the percentage of our life until this last year, as I would say, with 90% of the cases that are in this type of presentation. So you end up finding out some lesions that you may think they're consistent with cytomegalovirus infection, and a very minority of cases in which you have a pregnant woman which is referred regardless of the brain anatomy for advanced scanning because she knows she has seroconverted. But from now onwards, as I will show at the end of the CMV section of this talk, this will completely revert from now onwards, because at least in Europe, I don't know how it is in India, but considering the strong evidence of the positive effect of valacyclovir treatment in pregnancy, we are introducing in all our European countries the screening, serological screening for CMV because of valacyclovir. Okay. So if you suspect the US finding to be related to cytomegalovirus infection, look for additional extracerebral sign that may be present, such as echogenic ileus, and check maternal status, and then you carry out an amnio to see whether you have positive or negative CPR, and you make a viral load count to see how is strong and how is likely to have major damage, cerebral damage for the fetus. If you look at the mother and serological profile, the only reassuring profile is the absence of both IgG and IgM. Why? Because we do know that also if you have a positive IgG and negative IgM, you may have a reinfection. And this is why this is not enough to rule out CMV infection. At the same time, if you have positive IgM, so it's a very recent primary infection, or low avidity, if you think about reinfection with IgG already present, then amnio is a must, which should be carried out at least 6 weeks from the probable, from the likely timing of infection, because otherwise you will not be able to find the CMV in the amniotic fluid. And you see that the PCR is very, very sensitive. Now, when you scan and you schedule the examination or the serology for that baby, you should consider the clock of the CMV infection. So the CMV infection needs 3 to 6 to reach the placenta from the mother and abate the placental barrier and give a placentitis, so a thickening of the placenta. From then onwards, it will reach the organs, so the kidneys, and will be excreted into the urine, and so in the amniotic fluid, and you can pick that up by doing an amniocentesis. And then from that moment, it will spread to other organs. It takes 1 week more, and eventually it will reach the brain. So to reach the brain, you need 6 to 8 weeks from the original timing of maternal infection. So if you consider this point, the 2 points that you should have in your mind: first, you cannot expect any brain lesion if you scan such a patient before 6 weeks of pregnancy, 6 weeks from the alleged infection. And second, this is another important point, at least in those countries, it's not like that in India, but in Italy, you can terminate until 22 weeks. So we're rushing to do the amnio for the PCR at 21 weeks, because formerly it was thought that you could have a higher rate of false negative PCR results if you carried out an amnio earlier than 20 completed weeks of pregnancy. But nowadays, there are convincing results, at least from 2 groups in France, which is very active producing this type of studies, that also if you carry out an amnio from 17 weeks onwards, it's similarly reliable, provided that you have an interval of 6 to 8 weeks from the initial infection. Then you should look at extracerebral signs that are quite aspecific, because they can occur in any type of infection, or also non-infective lesions and conditions of the fetus. You have prefrontal edema, cataract, effusions. You may have splenomegaly, hepatomegaly, ascites, and so on and so forth. So very, very aspecific findings. And you see that the amount of these findings in this meta-analysis is very, very small. So you may have one or the other, or a couple of them, but their prevalence in the fetus, in infected fetus, is not so high. So you cannot rely on those specific signs. Here you have hepatomegaly together with some calcification. Here you have more recent cases showing you less prominent liver, but you see here there was also an initial rim of ascites around, and you see the indentation of the abdomen, which is typical of hepatomegaly. And then if you have any doubt, you can measure it. There have been some charts published over the last 20 years in in the literature. You can use them for the liver as well as for the spleen, because you may also have a splenomegaly, and then you can use those charts. Very rarely, CMV may also be responsible for a myocarditis, which is less evident if you look at the heart on grayscale, because it looks like a perfectly normal heart. But the moment you switch on the color, you see that there is a even very, very shy and minor bilateral atrioventricular regurgitation. And this is due to the inflammatory reaction of the atrioventricular valves, which are leaking during systole. And this may regress if the fetus survives, or may get even more worrisome. And then we go to the cerebral sign. And in that case, you see you have a wide range of possible abnormalities. Most of that are related to the fact that the CMV is killing the neurons, because it's got to the neural stem cells, as I told you, I showed you before. So the neuronal population is very, very small, because it's killing all the neural cells. And you will see the results not in the second trimester, but later on in pregnancy, because of course migration will occur later. And so if you see only a minor sign in the second trimester, you may end up with severe migration abnormalities and microencephaly later on in gestation. So this point should be focused when you talk with the patient. And then you have very minor and subtle cerebral signs, such as the subependymal halo. That is common to other viral infection. I don't have to expand the talk, but if you have a rubella infection or other viral infection, in very, very initial case of Zika, which we do not have in Europe, because I have not an area where you have a Zika virus, but still this is quite similar, and is ependymitis, okay? It's very typically seen both on the coronal aspect of the occipital horn and on the parasagittal view of the fetal brain. The signature of CMV is this, the presence of cystic lesions, which corresponds to necrosis at the level of the subependymal layer here from the inflammatory reaction, typically seen at the level of the occipital horn, or sometimes also the level of the cerebellum, and typically also at the level of the monoforamina you see here. These are not subependymal cysts, these are necrotic cysts from CMV. And you see here it was also already secondary hydrocephalus with dilatation of the third ventricle. And these are the parasagittal views showing you the same aspect of this necrotic cyst. And this is wide range of cases showing all the aspects that go from hyperechogenicity with the cyst, you have migration, you have polymicrogyria, incipient polymicrogyria here, calcifications scattered along the arterial walls, cyst, and so on and so forth. A typical site of calcification, considering that this results from arteritis, so it's the wall of the arteries which get calcified because of the inflammatory reaction, is the basal ganglia. And this is where you will find the candlestick appearance of this calcification, because these are just getting along the vessels. And you see this is the same fetus, and this was a close-up of a power Doppler showing you actually that the calcification were along the arteries of this case. And then you may have intraparenchymal lesions. I will go fast in this because I presented this in my previous talk. And also CMV is a major contributor of intraparenchymal hemorrhage, both supratentorial and infratentorial, as I showed you. And also brain atrophy, it's the final stage of CMV infection. And you see microencephaly and microcephaly. The agnostic value of ultrasound for CMV is very, very low. You see here, we are not good at detecting the infection. What we are good at, together with our companion, which is MRI, is to say whether an infected fetus is going to have any major cerebral sequelae after birth or not. And you see that the positive predictive value as well as the negative predictive value is quite high if you use the two techniques all together, but also isolation, ultrasound, and MRI are similarly powerful. What happens with the fetuses infected with CMV? At birth, you have 5 to 10% of severe infections, 5 to 10% of moderate infections, and the overwhelming majority are quite asymptomatic babies. So the outcome of these babies is very simple to remember. Of the severe cases, 30%, 35%, one-third will die of the infection, and two-thirds will have major sequelae. Of the moderate group, again, 30% will have major sequelae, and 70% will have a normal outcome. And of the symptomatic group, most of them will have a normal outcome with the percentage of neurosensory hearing loss in the range of 5 to 15%. These are the cases from all the studies published so far in relation to the outcome of the primary infection before the introduction of valacyclovir. And this is the game changer. As you see, the first study in Lancet is from 3 years ago, okay? And from then onwards, there have been other studies validating the fact that if you administer valacyclovir as soon as you have proof of maternal infection, the vertical transmission decreased from 30% to 11%. And also, the closer you treat the woman to the evidence of infection, more effective is the treatment in reducing the vertical transmission rate. So that's of crucial importance. And it works also on secondary prevention of fetal lesions, meaning that if you have an infected fetus because there's a positive amniocentesis and you keep giving valacyclovir, you abate significantly the number of cases which will have major sequelae, cerebral sequelae. So the flow will be like this. You have primary CMV infection, you give valacyclovir, 8 grams per day until you carry out an amniocentesis. You do it after 7 weeks, at least 8 weeks after primary infection. And if the amniocentesis is negative, then you can stop at valacyclovir. If the amniocentesis is positive, you can still, okay, and you can reassure the patient the risk of fetal infection is very low and the risk of long-term sequelae is virtually zero, and you deliver the baby. If you have a positive PCR, in some anxious countries, you may thought even to terminate just on the grounds of PCR, of positive PCR, without major cerebral lesions. But in most of the countries nowadays, with valacyclovir available, will not do a termination of pregnancy unless you have major evidence of major neurological cerebral lesion, and you keep on with the valacyclovir to the mother. Continue that, and the amount of babies that will have a major sequelae will be very, very small. So you keep an eye with neurosonography and MRI once only, neurosonography every 2-3 weeks. If there is nothing arising, you can deliver safely the baby. If there is any concern or any severe lesion, you can consider where this is applicable for law, which is not in Italy, this asterisk in this term, for late termination. So I have also some slides on parvo and on toxoplasmosis, but not to eat more time, I will close it here. So as far as CMV infection is concerned, also because Anita will cover the workup after me, so we'll keep it on focused on CMV only. Neurosonography is mandatory diagnosis to rule out the presence of lesions already in place, and follow-up. Should always be complemented with lethal brain MR to increase the predictivity, considering that the hyperintensity T2 are not clinically relevant lesions on MRI. So let's try to focus on that. Imaging techniques do not provide information about infections, only information about prognosis often. And neurosensory hearing loss damage cannot be diagnosed prenatally. And prevention of major sequelae is possible and effective with the valacyclovir. And from now onwards, all the studies and the prevalence of the cases with CMV that we will see in our everyday life provided that our countries and national health system will set up a system for screening and treatment of CMV infection, will abate by 95%. And the last slide, considering that, sorry, I will go to this last slide. Considering that this is my talk, I would like to thank Prashant for the brilliant organization. I would thank you all for your friendship and warm hospitality here in India. As is the case, anytime I come back to India, I will be in Kolkata in a few months from now for your National Congress of the Fetal Medicine Society. And again, I leave you with the brochures outside. If you want to join online or on site, you're welcome. Thank you so much for your attention.
Thank you, sir.
Thank you, Dario, for making us understand about the fetal brain, and your way of teaching and way of making us understand is phenomenal. Thank you for making us understand the fetal brain. Over to you, Sonia.
Next, I'd like to call upon Dr. Anita Kaul, ma'am. She is obstetric and fetal medicine expert from New Delhi. Ma'am is the clinical director at Apollo Center for Fetal Medicine, FMF, India. Ma'am has an special interest in fetal medicine, in utero therapy, laser, invasive diagnostic tests, twins, and prenatal screening for maternal and fetal complications.
Yeah.
Today, ma'am is going to tell about the prevention and the treatment of intrauterine infections affecting the CNS. Thank you,
Okay,
ma'am.
thank-
Over.
Thank you all, and thank you, Prashant, and all the members of the Fetal Brain Society. I'm going to just allude to toxo and CM. And one thing that I want to say is that we are not aware. To be honest, we don't think of congenital infections that much. The government of India has made syphilis, PDRL is a mandatory test, but everything else is much like we have with Down syndrome screening. It's sort of self-directed. You decide if you're going to screen or not. At least in the private sector, in some places, and we are heterogeneous even in the private sector. We do IgG rubella screen. But if I talk to my colleagues, some of them, and they say, and I ask them, do you even screen for rubella? They say we have to decide, should we do the dual marker, should we do rubella? And even that, if you have to choose between patients paying for blood, what do you choose? Do you choose Down syndrome screening, biochemistry, or do you do rubella screening? So it is quite different in our country. And of course, the debate that is now coming in is that should we also be doing CM? The current practice, of course, is that if some ultrasound findings, then we do something, otherwise we don't. So what are the management updates? Without doubt, it is the most common cause, CMV is the most common cause for non-genetic sensory neural hearing loss. It is true, we've always thought that it is something which happens in Western countries. CME is meant to be in the high income, old countries, and the prevalence is not so much. But the reality is that our population is so much that even if we are only 0.5%, 1%, it's still a huge number of cases. The other thing also is the fact that we don't have data. We don't know how many women are affected by CMV. So we can only go by the prevalence and data from other countries. And we think we behave like Brazil because we have this high prevalence of nearly 98%. So by the time women get pregnant, most of them have been exposed to CMV. And exactly as Dario said, is that now, even though we are exposed and we used to be comfortable that, you know, women are exposed and the primary infection is the problem, but now with this new data, which is saying that babies can be affected, whether you are primary or whether you're non-primary, we are stuck. So we need to really think about this. And if you look at the, okay, I can't find data on pregnant women, but if I'm looking at newborns with, or a pediatric population with hearing problems, they have hearing problems. We don't see them. But at age 2, 3, they have got hearing loss, and it is a burden. So we need to really rethink our congenital infections. I just want to remind you, when we talk about primary infection, we say it's happened for the first time during pregnancy. And when we are talking about non-primary infections, it could be reactivation of the same virus, or it could be a reinfection with a new strain of CMV virus, which is what is so difficult, which is why we can't get vaccines, because every time a new strain comes off. And the other thing, which now I'm much more aware of, is the fact that if the woman has CMV infection in the month or in the 11 weeks preceding her pregnancy, even then can you be affected, and even then can it be transmitted. So the periconception period, before her last period, after her last period, is important. And that history is also quite difficult to get. But as Dario said, if it's in the second and third trimester, it is not so bad. So the reality is, what happens is that we do a mid-trimester scan, and that is the time that we see that there are some features. And that's when we start thinking that if you see hepatosplenomegaly, that you start now asking the woman, have you got any, have you had any fever? Have you had any rash? But as far as CMV is concerned, that's really not so informative, because the majority are asymptomatic. So even if we proactively ask for this infection in women, we can't. So our diagnosis, to some extent, if there is seroconversion, and that is where we are stuck, because in India, unlike the West, we don't store booking bloods. So if I have a lady with the IgG, which is positive, in UK, I can go back and find what were her bloods at 8 weeks, 9 weeks, and again run IgG on that and see whether she is seroconverted in pregnancy. I don't have that recourse in India. And definitely in the second, in non-primary infection, it's not reliable. If you have IgM positive, it could be positive for a variety of reasons. If you have IgG, which is rising, it could be because of cross-reaction for a variety of reasons. So really, we are stuck with the timing of infection. And in the majority of cases, the only test we have is to do an invasive and to actually check for the virus. So I'm just showing you these two cases which came to us with non-visualization of the CSP. There was, the parietal occipital fissure was slow. This is at 25 weeks. It was very shallow. There was some ventricular megaly. We agreed that the CSP was disrupted. We could see calcifications, and we could see that the posterior fossa also had disruption and calcifications. There was a distorted permis, and there was a thin brainstem. But now with doing exomes, we routinely test for CMV, just because in the last few years we're sort of much more aware. And indeed, she was CMV PCR positive, and she opted for a termination. Another patient, which was one of our own, not someone who came afterwards, who we had done a first trimester screening for, and who just came for a routine anomaly scan, and the bowel looked a little bit echogenic, and you kind of think, if this is an echogenic bowel, it really, you're so confident you've done the first trimester, she's a low risk for Downs, and are you really that concerned? So we did torch. Surprisingly, the serology was actually strongly positive. It was like 500, 600. It was really quite high. And when she came back for a follow-up scan, all she had was this intrahepatic calcification. And then on an amnio, she also came back as saying positive. And again, we discontinued the pregnancy. But I regret the last case. I feel that we should have done things differently. And what are the things that we would do differently now? And this was started with the Beale group, where they found that there were some women, again, research done in France, that there were some women who had a diagnosis of CMV infection, but they chose not to discontinue the pregnancy. And therefore, the doctors thought that, okay, if we are continuing, we are telling these parents, look, you have these really terrible findings. You've got CMV, you've got hyperechogenic bowel, you've got ventriculomegaly, you've got all these things, and they're choosing to still continue, then should we do something? And they started on a compassionate care basis to start giving them valcyclovir. So it was started at around 28 weeks and given for a median of 7 weeks. And they found that actually when these babies were born, they were okay. There were about 20 fetuses and they were fine. And then this group then went on to do a proper randomized trial where they looked at in utero infection, again, valcyclovir against placebo to see how they did. And what they found is that if you give valcyclovir, you increase the number of asymptomatic neonates from 43% to 82%. So my point is that, as happens with us, we are very knee-jerk for doing terminations. So you get a blood report. I mean, we are so bad that even on maternal serology of IgMs, which are screened positive for rubella or for CMV, we terminate. And our threshold for discontinuing pregnancies is really low. Yesterday, I met Laurent over the gala dinner, and he has just come out with this paper, which was published in the FTD. And what this paper is suggesting is that we should separate out the signs, the brain signs of vertical transmission versus really bad brain lesions. And if you separate it out, you can then divide these babies according to this criteria into normal prenatal imaging and mild prenatal imaging over here, and severe findings. And all they did was a natural history. They just followed up these babies, the ones who had had infection in the first and subsequent trimesters. And they, on looking at the sort of natural history, if the imaging was fine, as expected, they had fairly normal outcome. Even if they had mild symptoms, which would have been my second case, where all I had was a hepatic calcification, at the most, this baby would have had hearing loss, which now is treatable. And it's the severe ones where you give them the option that, do you want to do anything? So for sure, I think that we need to discuss in utero therapy because of these two things. That one, it has been shown to be effective in utero therapy. And secondly, the majority of problems happen when there is first trimester problem. And exactly as Dario showed you, this is the algorithm that if you are lucky enough to document seroconversion in the first trimester, you do start treatment and you do the amnio and you decide, do you continue or not? But the key thing here is that you have to do really good brain imaging. I mean, you need to be sensitive to be able to pick up problems. In the original paper, they would also do lab tests and blood tests by doing fetal blood sampling and actually documenting that the viral load went down. But even if we don't do that, at least we can document treatment. But the problem, of course, is the dichotomy that we have with Indian healthcare, which is that in the public hospitals, which is where the majority of our babies are born, the women don't even turn up till mid-trimester. So this whole opportunity that we have of treatment in the first trimester is completely lost. And in our side, in the private sector, where they are quite diligent with their first trimester scan, we don't actually screen women for CMV. And therefore, because we do not expect anytime soon any kind of Indian guidelines, because our government has other things which they need to, which are more challenges, we are back again to the way we are with Down syndrome screening, that we individually need to decide that will we screen for CMV or not. and is it worth it? So at least in our unit, I think that the evidence is such that we've requested our obstetricians that from now on, please start screening for CMV. The other thing which is really important is actually to prevent the problem. And there is the CMV action group, and that's the website. And the things that we are meant to do when women come to us for antenatal care is to make them aware that, okay, don't use the same, and generally, as you know, the CMV is when they have sort of children and toddlers, that don't sit there and kiss them on their mouth. Then, avoid that. Make sure you do meticulous hand washing when you handle your child or the food, and make sure that you don't use their cutlery. To the extent now that NICE has incorporated in their antenatal care documentation that we must sit there and discuss CMV, and we must, proactively ask about their profession, if they're teachers, if they're with nursery school people, that we should discuss CMV prevention. As far as toxo is concerned, again, we are stuck. We know that the majority is primary infection. With all infections, if you can catch them in the first trimester, this is where you can do the most, you can help them the most. There is a situation of latent toxo where reactivation can occur, but it is extremely uncommon. But we are stuck again, not knowing what is our burden. So if one looks at the epidemiological data, it seems that we have about 50 to about 1.5 lakh babies being born every year with toxo in our country. The ultrasound signs are much as with CMV. Again, as you know, the transmission is mainly in the first trimester where it affects the pregnancy. But the main question here is that what do you give them? Because it is true they have the same role, the same prophylactic role as there is in CMV. So the question was that do we give them spiramycin? Does that work better? Does the pyrimethamine sulfadiazine, is that work better? Should we be looking for new chemoprophylaxis regimes? And for this, there was a trial, the Toxogest trial, where they gave this particular regime. They gave spiramycin, another arm, we gave the PS medicine, and again did an amnio at more than 18 weeks. So if it was negative, they stopped the medicine. But unlike CMV, you cannot stop it immediately because these trophozoites can be inside the placenta and they can keep getting released. So even if your amnio is negative, you need to still wait for a month or so, or even up to 6 weeks, to make sure that whatever residue there is in the placenta, even that, if you get a false negative on your amnio, just because you've tested it a little bit too early, at least you've covered those. And if by chance it is positive, you continue the medicines up to term and the neonatal period. In the trial, it did show that the PS regime works better, but you can't use it in the first trimester because it is teratogenic and spiramycin is better. But in our clinical situation, where what happens, that we anyway see them too late, probably between the two, this is a better regime, as the trial showed. The problem is that it is much more expensive, and if indeed any of you have gone to try for treatment, you found that it's much more easy to get spiramycin than to get the pyrimethamine and sulfadiazine. So that is a problem. I believe for us, at least in India, the costs are not so much, but I believe in the West, each tablet costs several $100s. So they're looking, and this is where the research is going on in toxo, that what could be other effective chemoprophylaxis methods. Because it is a strong combination that, we try and do other regimes, that maybe you give 3 weeks of PS and then 1 week of spiramycin and keep looking at all this. But again, there is primary in prevention, which is not to eat undercooked meat. Lastly, just coming to rubella, which also is a problem in our country. Again, we have no data, but it's thought that 1/5 of women, when they come to us, that they are susceptible for rubella. So I would absolutely encourage that we should screen, whether it's expensive or not, we should screen for rubella for women who come to us. Again, it is much more in the first trimester, but the point is that there is nothing. We have no cure for rubella. If you have documented, and I mean documented, which means it's on an amnio with a PCR serology, not terminating on the basis of bloods, the only treatment is vaccination, that we should be vaccinating women before. And fortunately for us, this is something that India has really taken on seriously. So we have a mission called the Mission Indradhanush, which started last year in August, and the government wants to eradicate measles and rubella. And obviously the idea is to catch them young. So children before the age of 5, ideally before the age of 7, they are trying to universally vaccinate. And this is something that, we can be really proud of. So from August till the time this WHO report was released, in 7 months, we had vaccinated 30 million children against rubella. So I think we are doing a good job, and hopefully this will be something of the past. So the practice points are just awareness. It's not something we think about. We are so bothered with Down syndrome. We're so bothered with the major things. We don't think of congenital infections. I agree in terms of priority. Do you do biochemical screening? Do you do basic ultrasound? Do you look for heart defects? Or do you try and do these subtle brain findings to think of CMV? But you all are, you've come to this conference, you're much more motivated and interested. So I think that we should think about universal screening for rubella, CMV, and perhaps toxo. So thank you all very much, and thank you.
Thank you, ma'am, for the informative talk. Now we'll disperse for the lunch, and we'll meet again at 2:30. Wait.
Thank you.